we'll be talking about the neurological examination of the lower limbs today, and I will take you through the key things we need to do. The first thing is to clean your hands and read the instructions. They're given usually written on the wall. So after reading the instructions and cleaning your hands, the next thing to do is to greet your patient and seek consent to proceed, telling your patient what you'll be doing. So good afternoon, sir.
Good afternoon.
Dr. Edu. I would like to examine your lower limbs. It will include me moving your legs and also checking for some of your reflexes. That's fine.
All right.
Okay. Can I proceed, please?
Go ahead.
Okay. Do you have any pain anywhere?
No.
Okay. So after that, seeking consent and also trying to tell the patient what you'll be doing. The next thing is to go to the foot of the bed. And when you get to the foot of the bed, what you need to do is to check for abnormal posturing of the lower limbs. Is there any abnormal posturing? So you may want to put the feet together and see whether there's abnormal posturing. In this case, we can see there is a lateral rotation of the left lower limb, and this might suggest weakness in the lower limbs. So the next thing to do is also to check for any obvious scars on inspection, maybe tendon release surgery scars, which is not present in this case. Then if there's any obvious muscle wasting, at times you might just notice that in mere looking the legs and the thighs as well. But if you want to be objective, though the time may not permit you to do this in the exam, so you get a landmark using the tibia tuberosity. You measure 18 or 20 cm up. This is like 20 cm up. Then you measure the circumference at this level of 20 cm. So this is what you do. Then when you do this, you try to measure the circumference here. So bringing it out here, we have like 46 cm. Then we do the same thing here. Checking for the tibia tuberosity landmark. Can you please let me pull up your shot a bit? Then we also measure the 18 cm up. So there must be a definite landmark. So do that, then check for the circumference. Okay. All right. So you try to compare if there's any difference. So it's about 46 as well. So the same thing you do for the lower limbs. You may want to measure 10 cm down from the tibia tuberosity and then check the circumference as well. Then the same thing here, measure 10 cm down and check the circumference. However, for the purpose of the exams, especially if the exam is for 5 minutes, you may just want to have a mere look and to see whether there's any obvious muscle wasting. As you might notice in cases of conditions like polio, myelitis, then also in cases of some muscular atrophy. Then the next thing is to check for, is there any involuntary movement which can be present, any fasciculations. So there are no obvious fasciculations. The presence of fasciculations will suggest lower motor neuron lesion, and this will be evidenced by muscle twitch. So you can check spontaneously if there's, check looking for spontaneous fasciculations. Then after that, you can try to tap. So I'll be tapping you a bit, if that's fine.
All right.
And see if there's any muscle twitch. All right. Or you can just do this and see if there's a muscle twitch or fasciculations. So I can't appreciate any now. So that suggests there are no fasciculations. And at times, just see if there's any obvious tremors. So the one way to remember this is using the mnemonic P Swift. So the P stands for postural abnormalities, the S stands for scars, W wasting, I for involuntary movement, F for fasciculations, and T for tremors. Then the next thing is to check for the tone. So while checking for the tone is the resistance to passive movement across a joint. So you're going to check across the hip joint, across the knee joints, and across the ankle joint. And you must check at the same, bilaterally. When you check for the right, whatever you check on the right, you must also check for it on the left. So again, I said it's the resistance to passive movement across a joint. So for the hip joint, before I touch, I'll tell him if, again, just to confirm, do you have any pain in your joint?
No.
Okay, so I'm going to move your thighs now. Right. I want you to relax as much as possible. So this is to avoid a condition we call paratonia. So if the patient fails to relax, then you might interpret this as hypertonia. So I'm going to move that. So I'm going to move your limbs for me, make it free as much as possible. So you can see the foot almost moving easily while I rotate, while I move the thighs, or while I roll the thighs. But on the other leg, which is outwardly rotated, you find out that when trying to do this, I notice that there's some resistance, across, the hip joint here. Then I'll go to the knee joint. There are two techniques. You can do this and try to tell him, can you relax for me? Let me do the movement. So you do the movement and look for the resistance. So then check the other one and check if there's any resistance. All right, so it feels a bit stiff here. All right, okay. So that's that. So I can say that at this point there's some hypertonia. Another way to check it is to do this. So you just tell him to relax as much as possible. They just try to lift it up. So you find out that the legs are relaxed here and they're moving easily. But on this leg where you have increased tone, when you move the legs up, the heel goes off the bed completely because of the hypertonia. So you do this 1, 2, 3, and you can see the entire leg moving up. In contrast to the other one where the heel was still on the ground. So that tells you that there might be some hypertonia there. So you can do that. So there are the two ways you can check for tone across the knee joint. Then finally, across the ankle joint, check for the movement to stabilize just above it. Then do this as well. Then the next thing is to check for the gross power. So can you move this leg up for me? So at least he has a power of 3+ for being able to move it up and sustain it in the air. Then can you move the other one as well? So he can't move it, so that suggests that the power is 1 to 3. So you have to check whether the power is 2 or 1 or 0. So can you move it in and out for me on the bed? Okay, so you can still move it horizontally without the influence of gravity. So I give you a power of at least 2. He was not able to do this. The next thing is to ask him to wiggle his toes for me. And if he's able to do that, that will be a score of 1. And if still not able to do that, then I'll give it a score of 0. Then after that, so I'll now check for the individual muscle groups. So the next thing is to check for the hip flexors. That's your iliopsoas. Can you push my hands up, please? Up, 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 up. So this seems weak. Then can I push my hands into the bed? Okay, this also seems weak. Then can you bring your thighs together, please? Okay, this seems weak as well. Then can you push my hands out? All right. Then the next thing is to do this. You want to check for the knee flexors. That's your hamstrings. Can you bring your heel towards your buttocks? Okay. Okay. Then can you do the same thing here? Heel towards your buttocks. Okay, that's weak. You can't do that. Then can you push my hands away? All right. Can you push my hands away? So that seems weak as well. Then finally, look at the foot. So can you press my hands down as if you're pressing a pedal? Can you do the same here? So that's weak. You can't do that. Can you push my hands up? Can you push my hands up? All right. So you can't do that. Then you check for the inversion and eversion. Can you push my hands in towards the center? You can do that here. Seems weak here. Then can you push my hands out, 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 out? So it seems weak as well. So you can also quickly check for your L5 and S1. So can you push my finger down? This is S1. What about here? So that's weak. Okay, you can't push my finger down. Then can you bring it up? Very good. That's L5. Then you can't do that. So the next thing is now to check for the reflexes. So one of the ways to remember the reflexes is that your ankle jack, the deep tendon reflexes, the ankle jack is 1, 2, that's S1, S2. Then the knee jack is 3, 4. Then the supinator jack is 5, 6. The brachial, the biceps reflex, that's 5, 6. 7, 8 is the triceps reflex. So one of the ways we can remember that, is one of the rhymes back in primary school days when they say 1, 2, buckle my shoe. 3, 4, knock at the door, but in this case, maybe kick at the door. Then 5, 6, pick up 6, that's for biceps and brachialis, pick up 6. Then 7, 8, lay them straight. So those are the root values. So since we are focusing on the lower limbs today, so we'll start, this is the technique, you let it relax, stretch the tendon a bit. This is your tibia tuberosity, this is your patella, so you're striking this tendon here, all right? So you strike the tendon, and when you hold your reflex hammer, and you let it drop on the patellar ligament or the quadriceps tendon, paying attention to the muscle contraction here. Can you please let me pull up down? So we'll look at that now. So I'm going to strike, and when I strike, I'm not going to quickly remove my patellar hammer. So I'm going to let it stay for like, like a second or so. All right. Okay, that's done. Then check out the other one. Support it. Then strike. Oh, okay. It seems some hyper-reflexia there. Then for the ankle jack, we'll do, we bend the knees, make it, bent out like this, stretch it a bit. You may not need to put it on the other leg, so this is good like this. Then you strike. Then this other one, strike. That looks increased. All right, so that looks increased there. That's the ankle jack. Then what you want to do at this point is also to check for your extensor plantar response. You can use your orange stick, or at times you may want to use the tip of your reflex hammer. So you check for the plantar response. The ideal response is flexor. So we come from lateral to medial in a single swipe. So that's the flexor. So pay attention to the first movement of the big toe. Then the other one, all right. Okay, that's similar as an extensor response. That's an extensor plantar response there. You want to check for your clonus. To check for clonus, bend the knees a bit, then dorsiflex and plantar flex the foot, then sustain it at the hand. So we're going to do something like this, 1, 2, then you sustain it. So if there's clonus, you exert some like flapping movements. So again, 1, 2. So you see some jerky, clonus movements. Anything more than 3, we suggest a sustained clonus. So you may also want to check for your coordination quickly. So can you move your heel on your shin, please, and bring it up and do it again. Okay, so that's checking for coordination. But if there is some cerebellar impairment, so it might not be able to do that, it will be missing the target. So it will demonstrate that for us now. Okay, let's assume there's some cerebellar impairment. So you see him moving this way, okay? All right, so missing the target. So that suggests there's some coordination problems. Then finally, so that's for the motor system. So it's important for you to read the instructions carefully. So the instruction says, do the motor system. So obviously you don't need to go into the sensory system. But if the scenario says, do a neurological examination of the lower limbs, you have to go ahead and also check for your sensory modalities. So the next one we'll check for is the fine touch modality. So it's important to remember the dermatomes. That your first pocket in the thigh is L1, the second pocket L2, the third pocket is L3, the medial side here is L4, the lateral side here and the dorsum is predominantly L5. Then the sole of the foot and the lateral border is S1. The major part of the back of the leg and thigh, especially the thigh, is S2. Then you sit, the 3-letter word S3, and on S3, that's your ischial tuberosity, and you shit, a funny way to remember, 4-letter word with S4, that's the perianal area. So you check dermatome starting from the feet, then you go up, all right? So you tell him what's going to feel like, so you should be aware. So you're going to feel something like this. Can you feel that?
Yes.
Does it feel like a cotton?
Yes.
Or what does it feel like?
I feel something.
Okay. So can you let me know when you feel it touching you?
All right.
Just say yes when it touches you.
Okay.
It's important not to prompt the patient when doing the sensory system examination. So it's wrong for you to say something like, when you touch the patient, it's wrong for you to say, do you feel it touching you now? That's wrong. So you don't prompt the patient. So what you just need to tell the patient is, as soon as you feel it touching you, just say yes. So we'll do it dermaton by dermaton. So close your eyes, please. So just say yes when you feel it touching you.
Yes. Yes.
That's good.
Yes.
Okay. So you can keep saying yes. Okay,
Yes.
if you feel it, that's good. Same here. Okay. So, you keep checking up to, and make sure you're checking the same area. All right, and you check, whatever you check on the right, you must check on the left. So it's wrong for you to complete your examination on the right, then now go to the left. That's wrong. Whatever you check on the right, you must simultaneously check on the left. So the next thing is also to check for joint position sense. For joint position sense, can you look at me, please? So this is up, this is down. So please, you do not hold the nail bed, you hold the sides. You hold the sides to get a good grip of your joint position sense, which is mediated by your dorsal column, just like your fine touch too. The fine touch by the cotton is also mediated by the dorsal column or posterior column. So the same thing here. So sir, this is up and this is down.
All right.
All right, so you hold it gently. All right, so close your eyes, please. So let me know whether it's up or down. What about now?
Up.
Hold on, please. What about now?
Down.
Now?
Up.
Very good. Then the next thing is to do, what about this place? So let me know whether it's up or down. Okay. All right. So what about, just say up or down, let me know.
Down.
You're not sure? Okay, that's fine. So if he doesn't get it right, you may want to go ahead and do, check at the level of the ankle and tell him this is up or down. So as soon as it's absent in the around the first metatarsophalangeal joint, you check for the ankles. Then to check if the joint position sense is intact. The same way you can just say this is up, this is down, and you see whether it's able to recognize that. So if that's impaired, that suggests a joint position sense problem. Then vibration sense problem, use a 128 Hz tuning fork, you set it into vibration, and you tell him, can you feel the vibration, please?
Yeah.
Let me know when it stops.
I stop.
Then the same thing here. So we do the same thing here again. On the bony prominences, you can strike the wall, but just hold the base of the tuning fork. All right. Can you feel anything?
Yes.
Can you feel the vibration?
Yes.
Let me know when it stops.
I stop.
Very good. Then do the same thing here. At the base of the first metatarsal. Anything?
No.
Okay. Okay. Then you keep going up. You can go to the medial malleolus. What about now?
Yes.
Let me know when it stops.
I stop.
Okay, very good. All right. Okay. Anything?
No.
Okay, that's fine. Okay. So it seems to be impaired on this side. So you can, set the prongs into action, or you can just strike the wall, or strike your, to set into vibration. But please remember that you hold the base and not the prongs. Then at times, if there's a needle tip pen, you can also check for pinprick in all the modalities as well. So I think after this, it's important to know that if the person does not feel the sensation up to the anterior superior iliac spine, any sensory loss below that suggests a peripheral neuropathy. But if the person tells you that he can't feel, can't feel the sensations, and it goes above ASIS, especially if it's affecting both lower limbs. If it's affecting both lower limbs and the person cannot feel your cotton wool, cannot feel your pinprick, or even the vibration sense, you keep coming up from the base of the first metatarsal to your medial malleolus, to your tibia tuberosity, to your anterior superior iliac spine, to your civic-sternum, and the person tells you, I'm not feeling it, then most likely it might be a spinal cord problem. So most of the time, spinal cord problems will have a sensory level, usually above the anterior superior iliac spine. Another thing that you might also notice is that there will be weakness in both limbs, and there will be some sphincteric incontinence. So you might get to the exam where you get to see a patient who is on urinary catheter or on Pampers, then the person can also move both lower limbs, then has a sensory level, then you think of his spinal cord pathology. So you want to complete your examination by telling the patient, checking the back of the patient, So you check the back of the patient by asking them to sit up, all right? Then you look at the back to check for, so I'm going to pull this up, to check for any deformity or any gibbous. You want to check for any spinal deformity. So that's what you're trying to check for. And you may also want to check for tenderness, at the back. And ask, do you feel any pain anywhere?
No,
Okay,
no.
so any deformity. Then you tell the patient to complete the examination. You will not look at the gait. Tell the patient to walk for you to know the kind of, if there's any gait impairment. At the same time, you might ask the patient to stand with the feet together and eyes closed to check for your Rombex, which might also be positive in conditions like where you have problem with the dorsal column. So it's important to know that the dorsal column mediates fine touch, vibration sense, joint position sense, and your Rombex. So it may be hard to just demonstrate all those signs in the exam. Finally, you might ask patient to tandem walk for you. That means to walk on a straight line while looking straight ahead to see if there's any cerebellar signs. So that brings us to the end of neurological examination of the lower limbs. Thank you.
Thank you.
Thank you very much, and thank your patient. Thank you so much. Then you clean your hands afterwards. Thank you. Then you can cover up your patient, and thank you.